Hello, everybody. Sorry I couldn't be there in person, but I hope the video will work. And I'm free to take any questions by phone, or you guys can email me on the details on the bottom of the slide. So I'd like to thank management of Clicks for inviting me to do this talk. And today I've been asked to speak about diabetes and vitamin B12 deficiencies. So these are my declarations in terms of my involvement with Big Pharma. And we're going to start with an overview of diabetes because that's central to this topic. We'll touch on the definitions of type 1 and type 2, the global prevalence, and a bit of the pathophysiology will come through in the course of this talk. And then the main topic for today is the importance of micronutrients in type 2 diabetes, the role of vitamin B, the role of vitamins in the metabolic regulation, and then we're going to try and focus on B12. So we're all here today because diabetes is a growing epidemic in Southern Africa. And if we look back at data from 2015, you'll see that we had about 2.3 million people estimated to have type 2 diabetes in South Africa. At the time, it was 7% of the population. What is worrying is that unlike the world data, where about half of the population remains undiagnosed with diabetes, in South Africa, from all of those who have diabetes, about 61% remain undiagnosed. So that's a worrying number. And so it was projected at the time that by 2035, we would have approximately 4 million people with type 2 diabetes in South Africa. And that would have represented a 55% increase. Sadly, we've already reached that number. So we're sitting with a growing epidemic. And the driving force behind that is obesity. So I always say that type 2 diabetes is the shadow of obesity. Now, it's worrying because in South Africa, over 56% of our females are overweight. Over 29% of our males are overweight. But if you look at obesity rates globally, it's the same trend. So over 650 million people in the world live with obesity. And if you take obesity and overweight, then that number crosses over 1 billion. 41% of women live with obesity. And in South Africa, if you take obesity and overweight, you're looking at close on to just over 2/3 of the entire female population being obese, and around 31% of men. Now, so diabetes is not going away, nor is obesity. Let's look at the challenge of how well we're doing with managing type 1 and type 2 diabetes. So on your left in pink, we see the average HbA1c in various countries with people living with type 1 diabetes. And you can see we're nowhere close to the control we're all aiming for, which is around 6.5% on the HbA1c. On the right, mainly in blue, again, different countries showing that we far in terms of reaching the targets we need to with type 2 diabetes. And most of these numbers are between 8.5% and 9%. And our goal is to get it to basically 6.5 to 7. But nowadays, most of the guidelines talk about aiming for remission in early diagnosis in some patients. So we do have a challenge on our hand. Now, one of the reasons why there is a challenge in getting to control type 2 diabetes is that gone are the days where in my day, when I qualified, you had type 2 diabetes, the basis was insulin resistance, and you asked the patient to diet and exercise. And 3 months later, if the HbA1c is still high, you get them to start with metformin. 3 months later, if it's still high, you get them to use an SGLT2. And then 3 months later, if it's still high, you would consider going on to insulin. Now, if we look how the physiology has expanded, we've always had the involvement of the pancreatic cell, because that's where the beta cells produce insulin. But we now also know of the incretin effect, which is where the GLPs play a role in terms of managing the foregut, and that speaks to the hypothalamus. We also know the role of the alpha cell, which is part of the pancreas, has expanded, and that glucagon, which is another hormone, plays a vitally important role in management of type 2 diabetes. On the background, what hasn't changed is the understanding around insulin resistance, and that happens at the level mainly at the liver, but the muscles and adipose tissues are not spared as well. And now we understand that there's an involvement of components in the brain that work on satiety, on appetite, and regulation of the sympathetic tone, and that in itself affects diabetic control as well. The role of the gut microbiome is expanding in many fields in medicine, and diabetes is one of them. And then immune dysregulation, a vitally important component, especially with type 2 diabetes, the role of the foregut, and then of course the kidney. Now you'll understand why I'm going there, because you can see if you guys at Clicks are wanting to start managing patients with type 2 diabetes a bit better, it can be done. But you need to understand that the pathways are very complicated, and one needs to empower oneself with that knowledge. And that way you can utilize this very complicated guideline or consensus statement that had come out. So we are now at a point in medicine and in type 2 diabetes where the treatment has to be individualized. So if you look right on top after the title, you'll see the first line of therapy is metformin. With a comprehensive change in lifestyle, we now need to try and aim for an HbA1c, and then downstream, you can see the guideline with all the different products. But one of the central components is still metformin. So that sets the background for why metformin is still going to always be part and parcel of managing most patients with type 2 diabetes. Let's touch on the metabolism of B12. So we'll look at an overview of vitamin B12 deficient absorption, because basically we get it from food. We can look at the role of B12 in DNA synthesis, red blood cell formation, and its role in the nervous system function. This is an overview in written form in terms of what happens with B12, but I'm going to move on to the next slide, which makes it a bit easier, especially if you're in the audience, to understand how B12 is derived in the body. So in the first circle up there, you can see that vitamin B12 bound to dietary proteins are found in certain foods, and then we consume these, and with mastication in the mouth, the salivary gland will release a product called heptacorin, and the heptacorin and the B12 complexed with the protein will then go downstream through the esophagus into the stomach. You can see in the circle number 2, you've got hydrochloric acid that's going to cleave the vitamin B12, which is in red, from the blue, which is the protein. The heptacorin, which was secreted by the saliva, now binds to the B12, and then it goes down into the foregut or the small intestines. And circle number 3 is showing that in the small intestines, pancreatic enzyme will cleave the B12 from heptacorin and let it be free. At that point, it will bind to intrinsic factor, which was made in the stomach, goes downstream. And then in the large intestines, you can see in number 4, you can see the brush border, and that's where absorption takes place, gets into the bloodstream, number 5, and then it gets into the body to do whatever it's meant to be doing, and we're going to touch on that. Now, what's also emerged is that in number 4, in the intestines, the gut microbiome plays one of the most important roles in the absorption of B12. And that in mice models have shown that if you wipe out the gut microbiome in these mice, with all of these factors in place, you will still not absorb B12. So let's look at B12 deficiency in diabetes. What is the prevalence of vitamin B12 deficiency in diabetic patients? We don't know. We don't know because it's not routinely tested. So let's look at the link between metformin and B12 deficiency. And the mechanism of action here in pink, you can see, is at the moment we know it's a twofold pathway. The one is that metformin will have a reduction in calcium-dependent membrane activity, and that's where the absorption takes place. And number 2, I alluded to the importance of the gut microbiome in the metabolism and absorption of B12, and so we know that metformin can alter the gut microbiota. So once we've had long-term use of metformin, you can see this chart. Go to your left. It shows reduced secretion of intrinsic factor by gastric parietal cells. So remember I told you this is a factor that's produced in the stomach, goes down into the intestines, binds to the B12, and that's where you get the absorption. It alters the binding of the intrinsic factor to B12 because of its influence on the tubulin receptors. And then it also alters the small intestine motility and the bacterial overgrowth. So this has a net effect in reducing vitamin B12. In the middle, you can see that there's an accumulation of B12 in the liver because of metformin consumption, and that's going to alter distribution and metabolism. And then to your right, you can see it alters metabolism and the reabsorption of bile acid. So metformin does play a role there as well. And the net effect is that these 3 pathways ends up causing vitamin B12 deficiency, which may then influence hyperhomocystinemia, which is not good from a cardiovascular perspective. And then on the bottom, you can see it impairs methylmalonyl-CoA, and I'm going to touch on that on the next slide, but the net effect is that there's going to be damage. So what? So what if there's a deficiency in B12? What does that imply? What's going to happen? Well, there are definitely clinical consequences, and there's 3 big ones that I'm going to talk about today. So in the first rectangle, you see hematological effects, and here the impact is twofold. One, on megaloblastic anemia, so it causes that, and it also has an influence on white blood cells. On the second rectangle, you can see it has neurological effects, where we know type 2 diabetes by itself can affect nerve function and cause complications in the form of neuropathy. But B12 deficiency contributes towards that as well, and cognitive decline. So let's touch on the anemia first. So anemia is the lack of hemoglobin, and there's many causes, but from a nutritional perspective, there's 3 major effects. 1, when there's iron deficiency. 2, when there's deficiency of folic acid. And 3 is our topic of discussion here today, which is a deficiency in B12. And so that results in what we call macrocytic anemia. What does macrocytic mean? Macro is big. So what happens is, you can see here in purple, you've got this red blood cell that is made in the marrow, but it's an immature red blood cell because the cytoplasm develops normally, but the DNA synthesis is impaired. And then we end up with defective red blood cells, and that has an impact, of course, on oxygenation. We mustn't forget that all of this process is happening in the marrow, and B12 is required for DNA synthesis, which is also important for white blood cells. So on the right, you can see it will also let out immature neutrophils. And so that is B12 deficiency's effect on the marrow. What about B12 deficiency in terms of neuropathy? So this is basically a cartoon looking at the nerves. And so you can see the bundle of nerves in yellow, and they're covered by a myelin sheath. And that is how communication happens through the nerve. So once we get B12 deficiency through 3 different physiological pathways with a reduction in SAM, which stands for S-adenyl methionine, with an increase in AMM, which is methyl malanoic acid, and with an increase in cytokines, we have the net effect where the bundle around the nerves, the myelin sheath, basically gets destroyed and causes neuropathy, which is pain in nerve. That sensation can be described as being a cold sensation on the feet. It can be a burning sensation. Some patients describe it as gnawing, as if a mouse is eating at your toes. And then some people just have pins and needles. All this is a manifestation of neuropathy, and you're getting different sensations because different fibers are being affected. What about B12 and cognitive function? So dietary intake of folic acid, vitamin B6, and B12 are vitally important. They get absorbed, get into the blood. And then what happens is if you have a decrease in these 3 nutrients, you end up getting an increase in homocysteine, which is an amino acid that was meant to be converted to methionine if the methylation pathway works well. And the methylation pathway is very much dependent on B12 and something called TMG. The net effect is with B12 deficiency, you're going to get hypermethylation, which is going to increase free radicals, and that causes neuronal damage. And that's where you can have cognitive decline. So is screening recommended? Well, not nationally, but if you suspect it in your patient with type 2 diabetes, then you must. So you should consider if a client's been on metformin for more than 4 years, if there's a presence of anemia, where they're looking a bit pale, or if you look under the eyes, they're pale, or on their hands, fingertips, they're looking a bit pale, or there's a presence of peripheral neuropathy, which is actually very easy to test for. Or in other high-risk groups, older patients that are not really consuming their vegetables and the meats as regularly as they're meant to, so they end up becoming B12 deficient, or in vegetarians and vegan patients where you end up having a vitamin B12 deficiency. So there's lots of products on the market, and I'm aware that this is a CPD function, so I'm not advertising any particular products, but I'm just going to show you a few to show you that there's quite a few on the market, and they're not all the same. So whether you're looking at this product or whether you look at some that are bound differently in methylcobalamin, which makes them more absorbable, or this is an important pathway where if you cast your eyes straight to the red portion of this, you'll see there's a word called homocysteine. Now, homocysteine is an amino acid that's supposed to convert to 2 o'clock on this graph to methionine, which is a powerful antioxidant. And if you look at homocysteine and you go straight down to 6 o'clock, it becomes cysteine and glutathione. These are powerful antioxidants, and they're important from an aging perspective. So it delays aging, and aging manifests as hypertension, diabetes, dyslipidemia, Alzheimer's, Parkinson's, degeneration of tissues, basically. And this entire pathway is dependent. If you look in the middle of the big circle, there's a word called TMG, trimethylglycine. Now, there's something called the MTHFR gene defect. So if you look at around 4 o'clock on the slide in red, you'll see that there's an increased prevalence of this genetic defect, that the bulk of the population may be sitting with a methylation problem. So even when you give them an oral B12 or a folic acid, unless it's methylated, that particular individual's body won't know what to do with it. And so that's why some products will have a methylated form of B12 levels. So that's why there's a variety of products, right? And so you've got to pick and choose what works well for your client. But this talk won't be complete. I know I was only asked to talk about B12, but one needs to understand that this is like a web, that all of these micronutrients need to be available to the client suffering from type 2 diabetes. Otherwise, there will be problems. So we're going to touch on vitamin D3, magnesium, and chromium. So vitamin D deficiency is central, and you can see in green arrows, it's directly linked to causing hypertension, contributing towards dyslipidemia and obesity. And then where you see blue, you'll see that there's a bidirectional involvement. That means type 2 diabetes causes vitamin D deficiency, and vitamin D deficiency contributes towards type 2 diabetes and the metabolic syndrome. And so from that perspective, the role of vitamin D3 in insulin sensitivity and glucose metabolism is very important. And vitamin D3 deficiency is very prevalent in the general population, but more so in patients with type 2 diabetes. And there are consequences. The consequence is that there's an increase in insulin resistance, more cardiovascular disease, and bone problems. So vitamin D touches type 2 diabetes in many ways. Now here, at a cellular level, if you go right down to the cell, you'll see in pink that vitamin D has direct access to the DNA. Unlike a lot of the other nutrients, their receptors sit on the cell membrane on the outside. So they still have to knock on the outside door to get into the cell, whereas vitamin D has direct access straight into the safe, as I would call it, the safe of the bank, or the DNA of the cell. And there it regulates quite a few things. But vitamin D, you can see on the top left-hand corner, plays a very important role in the receptor. And then at around 3 o'clock, you can see vitamin D plays an important role with calcium metabolism. And then calcium is important for depolarization to allow insulin into the cell. So it's complicated, but vitamin B12 and diabetes are very interrelated. So again, you get different types of vitamin D. Just remember that food has mainly vitamin D2, and one requires about 40 minutes of exposure to the sun to at least 40% of the body every day to convert D2 to D3. And because that doesn't happen, it's important to use vitamin D3. So it's just easier for the client. In South Africa, anything above 1,000 requires a script. And so not every patient can afford to go to a doctor to get a script. And so anything below 1,000 is easily available without a script. Anything more than 1,000 will need a script. So again, here you get different products. So a lot of the vitamin D3 drops are mixed with something called Ceph oil, which is inflammatory. That's why all of us try and use, I know it's expensive, olive oil to cook because that's the safer one. So some of the vitamin D3s are mixed cleverly with something called MCT oil, which is actually healthy. And then you get different types of oral vitamin D in different doses. Just dose titrate it to your client. What about magnesium? Now, magnesium controls over 300 things in the body, so it must be important, and it's important for type 2 diabetes as well, both in the metabolism of glucose and insulin action. And so its deficiency like vitamin D, is linked to insulin resistance and poor glycemic control. But importantly, it also is involved in diabetic retinopathy. Magnesium can be found in the dark green leafy vegetables, in nuts, in seeds, and its deficiency can result in a pro-inflammatory state. It can affect the metabolic pathways. It can affect hypertension directly, endothelial dysfunction, platelet function. The net effect is, from a cardiovascular perspective, we need magnesium. Again, I'm going to show you magnesium's role in the pancreas and then in the liver. But in the pancreas, you can see magnesium in red plays a role with the DNA right on the bottom at around 6 o'clock. It plays a role in the cell in terms of glycolysis. It plays a role, if you look at around 2 o'clock on the side, its role in cell receptor function and membrane depolarization. At the level of the liver, where insulin actually does most of its work, you can see in red here multiple pathways where magnesium is involved. Now, not all types of magnesium are equal. You get magnesium oxide, which is the worst absorbed in the market. So why is it on the market? Because people use it if they're constipated to go. Because it doesn't get absorbed, it makes the client have more loose stools. Then magnesium can come in a carbonate form. So magnesium requires an acidic medium to be absorbed. And we know how many of our patients are on a PPI where the acid gets switched off. So here, carbonate's not going to be a good formula for absorption. That's why some people come with magnesium citrate, it already providing an acidic medium for its absorption. And then some products will chelate it to an amino acid like threonate and glycinate for better absorption. So the best absorbed magnesium will be the one in glycinate form. Ideally, you want a slow release, and the maximum amount of magnesium you can get into a product is around 1,000 milligrams. So there's various products again on the market, some slow release like the one on the left, some quickly absorbed, some are fizzies. So an athlete who needs the magnesium right now will take it in the fizzy form. So you get different types. Again, tailor it to what your client requires. And then last micronutrient I want to talk about today, and I won't be too long now, is chromium. Now here I would say stay away from supplementation because too much chromium can be dangerous. But you need to know that like B12, like magnesium, and like vitamin D, it plays a very important role in the insulin action. It can be found on the bottom, you can see in grains, broccolis, and nuts. And again, here in black, you can see it plays a very important role throughout the cellular function of the beta cell. So, an overview now. It's important for you to look at the symptoms, and you need to diagnose micronutrient deficiencies. Overall, you can see that vitamin B12 and vitamin D can cause fatigue, muscle weakness. Neuropathy can be caused by vitamin B12, magnesium, and vitamin D3 deficiency. And vitamin B12 deficiency can relate to cognitive dysfunction. So anybody who's been using metformin for a long time, older people, high-risk groups like vegetarians, vegans, anybody with neuropathy, please check to see if they're well supplemented. So I'm going to end in the last 2 minutes with a case study. Here's a female patient with type 2 diabetes and vitamin B12 deficiency. She's 58 years of age, got type 2 diabetes for over 10 years, and has been on metformin, 1,000 milligrams, twice a day. Complaining of fatigue, generalized weakness, tingling and numbness in the hands and feet. So that's a sign of peripheral neuropathy. Had a complaint about losing balance and coordination, some memory lapses. And so on physical examination, we demonstrate that there is a bit of unsteadiness when they're walking, and then there is a decreased sensation on the feet. So the doctor here will assume that it's because of less than ideal control, because the HbA1c is 7.8. So it's suboptimal. However, this patient's B12 levels were very low, 180. And so also had a higher elevated homocysteine level. So here, she's been on metformin for 8 years, and we know that this impairs vitamin B12 deficiency. And so what happens is you give her some vitamin B12 supplementation. So I know you need a script, but you nurses are experts at injecting better than us doctors. So an intramuscular injection of vitamin B12, 1,000 micrograms once a week for 4 weeks, and then follow it up with a monthly injection will sort it out. However, if the client doesn't have access to an injection, give them an oral supplement with B12. Adjust the diet, adjust the medication if necessary. And in this client, you can see within 3 months, there was a marked improvement in the neuropathic symptoms. The numbness and the tingling started going down. Her energy levels improved, but more importantly, her concentration improved. So I do regular talks. They're free webinars. They're open to the public, but it's mainly for doctors, nurses, dietitians, physios, people in the medical field. So I always welcome questions. They can either be emailed to me through Leonie, or you guys can suggest topics. But I do about 1 or 2 webinars on a monthly basis, sometimes for my students at Wits, the rest of the time to the public. So the next talk will be on testosterone in females. And then next year, we started off with thyroid again. But thank you very much for your attention. And I hope you guys enjoy the conference. And I hope this talk has been fruitful for you. Thank you.